Welcome to the Heart Attack and Stroke Prevention Center of Central Ohio. I am Patty DeMattis, and I'm here today with my team, Patty Cosby and Dr. Eric Goulder. The purpose of this 30-minute video is to give you a clear understanding of what your recent CIMT report tells you about your risk for having a heart attack or a stroke, or developing diabetes or dementia in the near future, and how a prevention program can help you lower that risk. By watching this video prior to your call with Dr. Goulder, you will be prepared to understand if you have a problem, what can happen if you don't address it early, and a preventive solution you can start right away. Please make a note of any questions you may have, and we will address them on your personal consultation call. Prevention is the cornerstone of our practice. Our name of our practice is the Heart Attack and Stroke Prevention Center. It's never too early or too late to start prevention. So on your personal consultation call, Dr. Goulder will discuss your CIMT results, answer all your questions, offer a recommendation for your personal prevention program based on your risk level, and how to get started.
Thank you, Patty. That was great. So welcome everybody to the Heart Attack and Stroke Prevention Center. Just a little background here. Some of the stats about heart disease: 2,200 people die from cardiovascular disease every day in this country. The initial presentation that you have heart disease, almost half the time is either having a heart attack or just dropping over dead. If you're a woman over the age of 40, your chance of dying from heart disease is 1 out of 2. 64% of women who die with a cardiovascular event didn't even know they had plaque in their arterial wall. If you're a man over the age of 40, your chance of dying from heart disease is 2 out of 3. Over 75% of the heart attacks that occur are caused by a blockage that is not able to be detected by a standard stress test. And for men, if you've already had one heart attack, 25% of you will have a second one. So what we're going to talk about today is, what is a CIMT? What does it mean? What does it tell us? How easy is it to do? And so we're going to get started with that now. And just a little background on me: I'm a board certified cardiologist. I've practiced standard of care cardiology for 35 years and did all the things that you know cardiologists did. We did heart catheterizations and put in stents, and did stress tests and put in pacemakers and read echocardiograms looking at left ventricular, the pumping function of the heart and the valves and all that sort of stuff. And while I did that for 35 years, toward the end, I was getting sort of frustrated because I was seeing the same patient come back over and over again. And this little lady would come in, and it didn't have to be a little lady, and she didn't have to be old, coming in with a heart attack or bad chest pain. And we'd take them up to the catheterization laboratory and take pictures and see what's going on and fix it with a stent, pat them on the back, say, hey, we fixed it. We saved your life. We saved a lot of heart muscle for you so that you can go on and live a normal life. The problem is that 2, 3, 4 years later, here she comes again. She's having the same problem. She's having more chest pain or another heart attack. We weren't really fixing things. We were putting Band-Aids on 30,000 miles of arteries in our bodies. And so the problem is we weren't getting at the underlying root causes for the arterial disease process. And so I've now decided to call this whack-a-mole cardiology. If you've ever seen this arcade game, this mole pops up and you whack him with a hammer, and then this one pops up, and then this blockage pops up and you put a stent in here, and then this one and you put a stent in here. It's just crazy. We're chasing our tails on this stuff. So congratulations to you. You've taken the first step for a healthy, active lifestyle without having to worry about having a heart attack, stroke, diabetes, or dementia. And as you know, as Patty pointed out earlier, prevention is priceless, and it's never too early or too late to start looking toward your goal of optimal health. So if you go to your family doctor or a standard of care cardiologist and you say, okay, what's my risk for having a cardiovascular event? Well, they're going to get out their cell phone, because we all have this app on our cell phone, and it's going to have a cardiovascular risk score on it. And it's going to look at a collection of risk factors for cardiovascular disease to see if you are at high risk. It's going to look at your age, gender, top number or systolic blood pressure number, total cholesterol, good cholesterol, the HDL, and whether you smoke or not, and whether you take a blood pressure medicine or not. And you put all that into the app, and it comes up with a number. And it's based on a big study originally called the Framingham study, which was started in 1948. It's been tweaked a little bit since then, obviously. But if you're a 50-year-old man with a good blood pressure, cholesterol is under 200, like the laboratory says should be normal, and your HDL is in the 50 to 60 range, like the labs say is normal, and you're not on a high blood pressure pill, your risk of having a heart attack or stroke over the next 10 years is 5.5 to 6%. So here's the catch. It turns out that the risk calculators are really seriously flawed because they're looking at a collection of risk factors. These big studies like this 5,000 person Framingham study, they work for a big population group. And they'll even work for a little bit smaller group, so that if we took 100 men, if we went back here and took 100 men with all these numbers and put them in a room and came back 10 years later, 5.5 or 6 of them would have had a heart attack or a stroke over that ensuing 10 years. The problem is, I don't know if it's going to be you or if it's going to be these 5 or 6 guys over here. Okay, they aren't these risk calculators are great for large populations. They break down when they're looking at you as an individual. And we know they break down because there was a scientific study done where they were looking at 222 men and women coming in prematurely with a heart attack. Prematurely meaning that the average age for a man in our country for a heart attack is 65 years old. For a woman, it's 72. The men in this study were under 55. The women were under 65. The doctor had these people in the emergency room in the throes of a heart attack, and he had everything he needed to put into the risk score to see if he would have picked up with the risk score that they were at high risk of having that heart attack. He had their age, gender, blood pressure. They were drawing blood because they're having a heart attack, looking at their cholesterol, their good cholesterol, do you smoke or not, are you on a blood pressure pill? And what did he find? He missed 82% of the women and 66% of men at being at high risk for having that heart attack. So the risk scores really aren't very good. On the other hand, the CIMT is pretty helpful, okay? Because instead of looking at a bunch of risk factors, it's looking to see if you actually have evidence of arterial disease lurking in your arterial walls. And if we find evidence of arterial disease, we know that can significantly change your risk for having a heart attack or a stroke, and we're going to talk about that in a moment. So what does a CIMT stand for? Well, it stands for carotid, which is the artery going up your neck, going up toward your brain. Intima, which is this first lining layer of the arterial wall here, this dark pink layer right here. Media, which is the muscle layer here around there. And on the scan, when we do it, on the ultrasound scan, these two guys look the same. So we measure them both together and come up with the thickness of that and see how it compares to how thick it should be. Okay, so that's what the CIMT stands for. It's a simple ultrasound 20-minute scan of your neck. You don't have to disrobe at all. There's no pain. We could do it every day. There's no radiation involved. Here's what a typical scan would look like. Here comes the carotid artery up the neck. And right here at this line, it's going to widen out into what we call the carotid bulb before it branches right here into the internal and external carotid arteries. And what we're looking for on this scan is a couple things. Number one, this bright white line here is the outer wall of the artery. So we're going to come down a little bit south of the carotid bulb and the computer is going to draw this box and measure how thick the lining layer is. And you can see it's not smooth. There's lumps and bumps in there. And so it's going to measure how thick that lining layer is at 100 points in there. When you get a CIMT done through our office or from a number of other places, the protocol is that we come in at about a 45-degree angle on both sides. We come towards the midline as far as we can and get a good picture. We come to the outside as far as we can and get a good picture. And then, so we're going to have 6 of these boxes. So we're going to average all 600 of those data points and come up with how thick your lining layer is. And then if you follow this lining layer out a little bit farther into the carotid bulb, it gets even thicker here. So this is what some plaque looks like in this carotid bulb. And we'll talk more about that in just a moment. So what your CIMT tells us, it provides information about your arterial age. We can determine the thickness of your arterial lining layer down to 0.2 of a millimeter. We know how thick this lining layer should be for everybody from ages 5 to 80. We've got scientific studies that tell us that. It's a little thicker in men than women. It gets thicker as we get older normally. But if your arterial age, and I'll show you how we calculate that in just a minute, is more than 5 years older than your current age, it suggests that you've got cholesterol, and your body's response to that cholesterol which is inflammation building up in your arterial wall. And it's really the inflammation that's driving the whole process, okay? And so that can be highly predictive of your development of a stroke or a heart attack or a mini stroke if it's increased, that lining thickness. It can also tell us, the CIMT can also tell us if you have plaque. The definition of plaque being an area of thickening of 1.3 millimeters at any point in the arterial wall. And the plaque comes in three flavors. It can be either soft, which means it's all cholesterol and inflammation in the arterial wall. This is the most unstable type of plaque. It can be heterogeneous or mixed, which means it's partially soft and partially healing. It's getting scarring and calcification in it. And that's starting to stabilize a little bit. Or it can be echogenic, which means it's a rock pile. The ultrasound beam can't even get through it because it's all calcified and it's the much more stable type of plaque. So the question is, what do you look like on the inside? Are your arteries aging faster than you are? And so if your arterial age is within 5 years of your chronologic age, we're going to consider that bell-shaped curve stuff, and you're going to be called normal. Okay, so if you're that 50-year-old guy we talked about, if his arterial age is anywhere between 45 and 55, we're going to call him normal. If the arterial age is between 6 and 10 years older than you are, we're going to say you're at moderate increased risk because you've got cholesterol and inflammation building up in that lining. And then if your arterial age is over 10 years older than you are at severe increased risk for having a cardiovascular event, a heart attack or a stroke over the next 10 years. And so plaque is just that buildup of cholesterol and your body's response to that cholesterol getting in there, which is inflammation, which starts developing when we're even pretty young, even in our second decade, and moving on into as we get older and older. By the time we get into our 30s and 40s, it's not uncommon to see plaque in people's arteries. When they did, and the reason we know this is when they did autopsies on the boys killed in the Korean War, they looked at the arteries, and they found evidence of plaque in these 20 and 25 and 30-year-old men. So it's a common problem in our country, and a lot of time I'll get people say, well, I tell them they've got plaque in their artery. Is that normal? No, it's not normal, but it's common in our country. By the time we get to be 65, 80% of us have evidence of arterial disease. So what causes the heart attack or a stroke? Well, when this plaque develops, and this is all cholesterol and inflammation here. This bit right here, a little bit different looking, is the muscle layer of the arterial wall. This is the outer wall here, and then it's got this little fibrous cap over it. When that fibrous cap ruptures, and it ruptures because of the inflammation going on down underneath it. When it ruptures, your body tries to heal it. Just like when I nick myself shaving, or when I cut myself in the kitchen with a knife, or working out in the yard, I'm going to get a scab there. And that's the same thing that happens inside the arteries. The arteries your body tries to heal that ruptured lining layer with a blood clot. Your coronary arteries are not very big, okay? So the coronary arteries in the midpoint in a man may only be 1 millimeter to 1.5 millimeters diameter. It's not going to take a whole lot of blood clot in there to plug up that artery completely, and it's the blood clot that causes the event. It's not this plaque, okay? So if plaque is present on our CIMT, that means you've got a significantly increased risk of having a cardiovascular event over the next 10 years, as much as 40 to 80% increased risk, okay? So we'll talk about that in a minute. So the question is, how bad does a blockage need to be to cause that heart attack, okay? And doesn't a stress test, we all know about stress tests, doesn't a stress test pick up the bad blockages that are going to cause that heart attack? Well, actually, all a stress test can tell us is if you've got a blockage that's so bad, 65 to 70% blocked, that you're going to need a stent or a bypass to fix it. If you've got a milder blockage, one that's not causing you any symptoms, under 65% blockage, your stress test is going to be normal. You're going to get a pat on the back, and you're going to be told you're doing fine. So I don't know how many, when I put this up there, I'm dating myself. This is a 1960s movie called The Time Machine, done by Orson Welles. This is our hero, Rod Taylor. And most people think I'm pretty geeky when I put this up. But this is New Year's Eve, 1899. Rod Taylor just said goodbye to his buddies. He's built this time machine. He hops in his time machine and goes off into the future. And that's the rest of the movie. So if we had a time machine and we could take everybody who's coming in today with a heart attack and go back to yesterday and do a stress test on them, what will we find? what we would find would be that 14% of the time that stress test would be abnormal because they had blockages of 70% or more. However, 86% of the time that stress test would be normal. They would get a pat on the back and they'd be sent home and say, you're fine. And yet they're going to come in tomorrow and have a heart attack. The problem is that in medicine, we've conflated a normal stress test with no evidence of arterial disease, and that's not the case. A normal stress test means that you do not have a severe blockage. You can have a milder blockage, and you can see here, it's the milder blockages that are going to get us all in trouble. So as we talked about earlier, it's those soft blockages, those soft plaques that are the most likely to rupture because they're full of inflammation. That's what drives everything. It's what makes the plaque grow. It's what makes that fibrous cap over that plaque get thinner and thinner and finally rupture. The heterogeneous or mixed plaques can still rupture, but they're starting to stabilize. And then the echogenic or calcified plaques are all stable and very unlikely to rupture. So let me just give you some examples of what we're looking at. If you've got your report in front of you, you can follow along. If you don't have your report, I'm going to explain all this, a lot of these numbers to you. So in this example, this is a 64-year-old guy, okay? And it says here his arterial age is 75. How do we come up with that? Well, this is the number right up here on top. This is your IMT, your intima media thickness. That's the average of all 600 of those data points I explained to you. And so you can see that number is 0.88 millimeters. And so now we're going to come down here to this graph on the bottom, and we're going to find the 0.88 millimeters right here. On this graph, I cut it off. I did not cut it off. It's down here on the bottom. You can see on the x-axis is the patient's age. So this is based on studies we've done on everybody from age 5 to 80, and so of normals. The blue line is normal for man thickness. The magenta line is normal for women. So we're going to come over here to this guy. 0.88 millimeters, follow it along until it hits the men's line. So that's way over here, drop that down, and that's where we get the 75 for his arterial age. His arteries are 11 years older than he is, and if you remember what I said earlier, that puts him at severe risk of having a significant event. And then the next thing we're going to look at is this stuff over here in red, and you're going to see that he does have plaque under here under plaque burden. He's got 4.4 millimeters of plaque. Remember I said plaque, the definition of plaque is a 1.3 millimeter thickness or more. So we look for plaque in 3 places on each side. The common carotid artery where it's coming off the aorta and coming up the neck, the carotid bulb where it's widening out, and then the internal carotid artery where it's going on up to your brain. And so you can see here, we're only going to count the 1.3 millimeter or more thickness areas, and so he's got plaque in each carotid bulb, right and left, and also the common carotid artery on the left. This 1.1 doesn't get added in. If it was 1.3, it would, and his plaque would jump up right now by that, and he would have 5.7 millimeters of plaque. All right, next example. Here's a 70-year-old lady. Okay, and so we're going to look down here and look, her arterial thickness is 0.70. Right here, and it says that her arterial age is 61. So let's see how we found that. We're going to come down here to the 0.70, follow it along until it hits the women's line, and it hits the women's line before this red dot. Okay, here's a normal thickness for arterial age would be right here. Here's where we're going to drop that down. That's where we get the 61 for this lady, and you can see she's got, however. And so that would say, your arteries, before we got there, okay, if we were just looking at the thickness, we're going to say, hey, your arteries look great. They're younger than you are. That's fabulous. But then we look down here and say, oh, she's got plaque. Plaque trumps everything. So she's got plaque in each carotid bulb, 2.0 millimeters in the right carotid bulb, 1.7 in the left carotid bulb. It's both heterogeneous, which means we treat heterogeneous or mixed plaque the same as we treat soft plaque because there's still inflammation going on in there. It's still at risk of rupturing. Next example is a young man, 29 years old, okay? He's 29 years old. When I did his scan, I said to him, and this is why I shut my mouth now and don't say this anymore. I said, this looks pretty good. Here's a picture of his lining layer, and when I'm doing this scan, I'm saying that looks pretty thin. The problem is that it's really hard for me to tell by eyeballing this, the difference between his 0.6 millimeter thickness and the 0.52 millimeter thickness that would be normal for him. That's a very small difference on this scan. But his arterial age is 42. His arteries are 13 years older than he are. This kid is at significant risk of having a cardiovascular event. And what a blessing for him to know at the age of 29 that he's got issues and he needs to change his life around. And here's one more example. This is a 34-year-old lady. She's, you can see her arterial age here is 42 by looking at that 0.54 millimeters, which is thicker than it should be. If we came down here, it's a little hard to see here. But here's what I want to show you. Here's her scan, okay? Here's the beginning of the carotid bulb. There's the lining layer down there in the common carotid artery. This is the branch point where it goes from the common carotid bulb into the internal carotid artery right here. And she has got this whopper of a soft inflammation. It's labeled as heterogeneous. There's a little bit of thickening, a little bit of calcification, but this is a mostly soft, very dangerous plaque in this 34-year-old lady. So this is why we do this scan, because if you took this 34-year-old lady and sent her to her family physician or any standard of care physician, they calculated her risk score, they would tell her that her risk score is somewhere around maybe 1.5% risk of having a heart attack or stroke over the next 10 years. And, next thing you know, she's going to be having chest pain or shortness of breath and fatigue a year or two from now. And she's going to say, I just saw my doctor that I had low risk for having a problem. That can't be my heart. And she would go on and have a significant heart attack because she was told that she was at low risk. And that's where these risk scores fail us. I'm going to skip that. So if you've got increased arterial age, or even worse, you've got plaque, what does it mean? Well, to find out what it means, they did a huge study. They took 10,000 people and did these carotid scans on every one of them. They were all 35 to 65 years old. Nobody had high blood pressure, diabetes, or cholesterol issues. They did the scans and they said, go away. We want to know, what does it mean if we find early asymptomatic arterial disease just hanging out in your arterial wall that you don't know it's there, and don't do anything about it? Because we don't know what it means if we find early arterial disease. It may sound unethical now, but that's actually what we do all the time in this country, because not very many people get CIMTs done to look and see if they've got arterial disease. Not many people get coronary artery calcium scores done, another non-invasive way to test and see if you've got arterial disease. So here's what they found. The average Framingham risk score, cardiovascular risk score for this entire group of 10,000 people was 3 to 5%. That's this line here. If you were normal, if these people were normal, and there were almost 8,000 of them out of the 10,000 that were normal, they had normal arterial age, no plaque. Nothing happens to you. 10 people out of almost 8,000 had an event, 1/10 of 1% event rate over the next 10 years. So even if they had a risk score of 5%, we now know that they are at very low risk of having an event. If we find an increased arterial age, their lining thickness is thicker than it should be, now their risk is not 3, 4, 5%, but is doubled or almost tripled to 8 to 9%. And then if we find plaque in somebody with no high blood pressure, no diabetes, no cholesterol issues, over the next 10 years, their risk is 40% of having an event. And that's if you've got plaque on your score, on your scan, don't get too upset yet, because this is the risk to you of ignoring the problem, of saying, Goulder's nuts, don't pay any attention to him. I don't care. And so the next question is, we've alluded to this before, is what makes that plaque rupture and cause that event? And as I've told you before, it's inflammation. The question is, and what we do here at the Heart Attack and Stroke Prevention Center is we look and see with 6 or 8 really good blood and urine tests, are your arteries inflamed? Are your arteries on fire? Because that's what drives everything. And so we know it's inflammation that's the underlying driver of this whole process. It's what takes your arteries up here from being normal to having increased arterial age with cholesterol and inflammation starting to build up, to having that plaque form because of that inflammation, having that plaque rupture because of inflammation. And so if we go look for all the things that we know of that drive the inflammatory process, things like obstructive sleep apnea and low vitamin D, and inflammatory diseases like autoimmune stuff like Sjogren's, rheumatoid arthritis, lupus, ankylosing spondylitis, all those kinds of things. Insulin resistance, 1/3 of the country is insulin resistant and doesn't know it. This is huge. Periodontal disease and endodontic disease. There's 5 high-risk bacteria in your mouth that can live in your mouth that help drive the arterial disease process. And the standard things we know, the high blood pressure and high cholesterol. Psychosocial stress is huge. So if we look for all these things and figure out what's affecting you and get it under control, everything goes back the other way. If you've got all you have is increased arterial age and no plaque, we can make that go to normal. If you've got plaque, and it's soft and inflamed, we're going to shrink it down and calcify it. It takes about 5 years to do that. And we may not make it go away. If you've got a 2 millimeter plaque in there, but what we're going to do is stabilize it. We can all live with atherosclerosis. What we cannot live with is soft, inflamed plaque. And so, if you've got increased arterial age or plaque, you've got a significant increased risk. The consequence of it, if you don't do anything about it, is it's gonna cause you to have a heart attack or stroke. It's gonna keep on progressing because you've got these underlying inflammatory issues that you're probably not taking care of. And so the answer is, together, we need to work on solving that problem so that we can prevent you from having that heart attack or stroke. And to do that, we need to understand your personal risk based on blood pressure, cholesterol, vitamin D. Do you have bad periodontal disease that we need to worry about? Do you have insulin resistance or diabetes? What are your genetics like? The same diet is not the right diet for everybody. We need to know something about your genetics to help you with lifestyle recommendations. And so, we know that it's the inflammation that gets everything out of whack. If we reverse it, everything gets better. And so most of what we do is based upon lifestyle modification. If you follow the right pathway of doing something for your mental health and eating a proper diet and getting some routine exercise and getting enough sleep and getting good quality sleep because finding out that you don't have obstructive sleep apnea or upper airway resistance syndrome. You don't have, when we typically think of somebody with obstructive sleep apnea, we think of those overweight people with the big neck. Not everybody has to have that to have sleep issues. And we get your oral health under control. If we do all those things right, it revs up a whole bunch of genes that gets us where we want to be 20 years or 30 years from now. Active, have all our mental faculties, being able to enjoy, I don't care if you play golf or not, but being able to enjoy life and enjoy all those milestones in your kids' lives and grandchildren's lives and all that sort of stuff. Or you can take the wrong pathway and say, I don't care that I've got prediabetes. I don't know about it. I'm not going to look. I don't care if when I brush my teeth, I get a little pink in the sink. That's okay. I don't know if I've got obstructive sleep apnea. It doesn't matter. I'm not exercising. I'm not eating a right diet. I'm eating lots of too much full-fat cheeses and dairy products and lots of red meat and not enough fruits and vegetables and all that sort of stuff. And all that revs up a whole bunch of genes that gets us to this point where none of us want to be. So that's it in a nutshell. The CIMT really tells us, do you have disease or not? And it's crazy in this country. We never look to see if you've got arterial disease. I shouldn't say never, but it's rare that physicians look to see if you've got arterial disease. It's like saying, we're never going to check your blood pressure until you come in having a heart attack or stroke, and then we'll check it. And if it's up, oh, look, you've got high blood pressure. We should check it instead of treating it 30 years earlier. Or when you go to the eye doctor, he never checks the pressure in your eye to see if you're at risk for glaucoma until you come in saying, I can't see very well. Well, let's check the pressure in your eye. That's what we do. This is the leading killer in the country, cardiovascular disease, and we don't look to see if you've got it. Congratulations to you for taking that first step. Okay, I'm going to give you back to Patty, and she's going to talk to you more about how all this works.